Hello again, Pinehurst team. I am back today to talk about how important the language you use in your documentation really is, especially when we're distinguishing if a condition is active or historical. The use of history of in a statement can be very confusing and misleading. Providers sometimes use this statement for chronic conditions that are actually active but are stable or controlled or with ongoing treatment. However, in the eyes of a coder, and more importantly, in the eyes of CMS, when the words history of are included in the provider's diagnostic statement, that condition is considered to be resolved, cured, or no longer impactful to the patient. Not only do the different uses, meanings, and interpretations of the phrase history of cause confusion, they also lead to increased and typically unnecessary provider queries and ultimately will prevent us from accurately capturing our patient's burden of illness. CMS does have guidance on when to capture diagnoses, which states physicians should document and code all conditions that coexist at the time of the encounter, visit, or admission that may require or affect patient care, management, or treatment. Remember, when coders are reviewing your notes, they will ask themselves if there is documentation showing that the condition was tampered with. Please refer back to the supporting documentation coding corner for additional details. I did, though, include the elements of tamper as well as the details that are really showing the support that coders are looking for. Now I'd like to quickly walk through the most common specific areas relating to historical versus active conditions that cause the most issues. The first area is active diagnoses that are stable or controlled or where there's ongoing treatment or management. That is the treatment or management, not necessarily at that visit as well. These include chronic ongoing conditions like diabetes, CHF, COPD, AFib, and stable angina. CMS actually offers some specific guidance here as well, stating coexisting conditions include ongoing conditions that are generally managed by ongoing medication and have potential for acute exacerbations if not treated properly. These can affect multiple body systems, meaning that the diagnosis is likely taken into consideration for medications, tests, and other treatments for the diagnosis that the patient is being seen for. Also, it is likely that these diagnoses would be part of a general overview of the patient's health when treating coexisting conditions for all but the most minor of medical encounters. So basically, if you are taking the diagnosis into consideration for any reason, that technically should be included as a diagnosis for that visit. So we'll keep in mind this guidance from CMS, but we'll move on to the table on the right, which highlights the most common diagnoses where there is a big discrepancy between what the provider documented and what coders or CMS interpret from that documentation. The simple interpretation errors here do prevent the actual diagnosis from being captured appropriately. The first example I'd like to highlight is angina, which is the green boxes on the top. Often, the code for stable angina is not used in patients because they are not having angina currently. But if their angina is controlled because it is being managed by the use of long-acting nitrates or Ranexa, then it is actually an active diagnosis, not a historical one. Patients who are being treated for angina and are controlled without symptoms are considered to have stable angina and should have that active diagnosis code reported. Another good example is AFib. These are in the pink boxes. I have 3 examples actually that are interpreted each a little bit differently. The first one, history of AFib, really is telling CMS that it is no longer an active or treated diagnosis. It is completely cured. When there is ongoing management of the rhythm or an anticoagulation, that is actually an active diagnosis and should continue to be active while there is ongoing treatment. However, if there is a procedure like an ablation that results in permanent return to normal sinus rhythm and there's no longer a need for anticoagulation or any other treatment, then the diagnosis should change to a history of. So we can see in the middle box, AFib controlled on digoxin, you should really have that as an active condition. However, AFib post-ablation is now a historical condition. There are 5 other examples of how documentation is interpreted by CMS on here as well. Please review and let me know if you have any questions on those. I also want to call our attention to a couple of diagnoses that can be active, resolved, or historical. This is at the bottom of the slide. These diagnoses typically, or the main diagnoses here, are alcohol and drug dependency, as well as major depressive disorder. Please note that when documenting and coding as historical conditions, there is not an HCC value or value associated with either of these. However, if you do document and code these conditions as being in remission, those do carry a value. Despite the potential value, though, we always want to aim for accuracy. So alcohol and drug dependence in remission, many payers do recommend always using a dependency in remission code once a patient is dependent on drugs or alcohol but is no longer using, versus using a historical or a history of dependence code. That is certainly up to the provider's judgment, but that is the typically preferred way. Also, major depression in remission, just a note that this diagnosis can be used when a patient has depression but has been free from depressive symptoms for several months, even if they are receiving ongoing treatment. The next problem area are acute diagnoses that are sometimes coded incorrectly. Acute conditions generally develop suddenly and last a short time, often only a few days or weeks, and this means that the acute diagnoses should only be used for that short period of time as well, days or weeks. Once the acute diagnosis has received treatment or resolves, it should no longer be coded or documented as acute. Caution should also be used when adding acute diagnoses to the problem list, as diagnoses can get stuck there and used repeatedly in the future, and all of them being inappropriate. There are also some acute conditions that should only be documented or coded at an inpatient or ED visit. The diagnoses listed at the top are examples of conditions that should only be on inpatient or emergency room claims, unless there is clear indication that despite being seen in the office, the patient was urgently sent to the emergency room. Those conditions are intestinal obstruction, acute PE, acute respiratory failure, cardiac arrest, acute DVT, initial fractures, post-op complications, and poisonings. In addition to those, there are two additional acute diagnoses that really are the two most commonly misused and misdiagnosed conditions. Those are CVA and myocardial infarction. I also want to note that both of these diagnoses are two of the most commonly audited and scrutinized diagnoses year over year with CMS, as they are also aware of how often they are both misused. However, despite being two of the most commonly misused, these diagnoses do actually have very strict guidelines from CMS on when to use them. First, we'll look at CVAs. The active code should only be used for the initial event while the patient is in the hospital setting. This code should never be used after the patient has been discharged. That is a one-time only use. If the patient has a new CVA, you could still use a historical code as well as the new one. Once the patient is discharged, there are two options. It can be reported as a historical CVA, or if there are any residual effects, you can code, or you should code it as a stroke or using a stroke sequela code. So the residual effects can be present from the onset or arise anytime after that acute phase. There really is no time limit for using the stroke sequela codes. Those are in the I-69.3 category. However, if the patient had a stroke, there are no residual effects, no deficits or of any kind, then the history of stroke code, the Z86.73, should be used. The other one is myocardial infarctions. So the initial MI code should only be used within the first 28 days from onset. After 28 days, you will want to use the I-25.2 or old MI, no matter what. If a new MI occurs within those 28 days, you can use a subsequent MI code in addition to the initial code, both of which will change to that old MI code after 28 days from onset. And finally, another huge problem area is neoplasms. Just want to note that coders will always defer to the provider's judgment for deciding whether or not a neoplasm is active or not. However, this slide does contain the generic information that helps us to figure out and helps CMS to figure out if the neoplasm is active or if it's historical. Basically, a cancer diagnosis indicates that the patient has an active disease. When patients do not have active disease anymore, or patients that do have active cancer may or may not be receiving treatment. So, active treatment includes surgery, chemo, radiation, hormone therapies, or watchful waiting. If the provider and patient opt out of treatment or decide to go with watchful waiting, that is also considered active. I will also note that the cancer can be active for up to 10 years with hormone therapy if it is used that entire time. Once the malignancy has been excised or eradicated, though, and there's no further treatment directed, that should be considered a history of code. If there is a primary cancer that metastasizes to a secondary site and that primary cancer is eradicated or a historical condition, the secondary cancer could still be an active condition and will still be active for as long as that is receiving treatment. Also, there are some in remission codes here as well. So an example of leukemia in remission. I think leukemia and lymphoma are the only ones that are specified as in remission. Those do have a value versus using the historical condition. So please be careful when using those as well. As always, if there are any questions, concerns, comments, or anything else, please do not hesitate to reach out. Thank you very much for listening. Have a great night.